Welcome to the Deep Dive. We're here to give you that rapid, focused download on critical topics, especially when you're prepping for those big orthopedic exit exams like the FRCS or your fellowship exams. And today, we're really zeroing in on high tibial osteotomy, HTO, and also touching on proximal fibula osteotomy, PFO, specifically for varus deformity. Now, this whole deep dive is based squarely on the fantastic Ortho Made Simple notes you can find on the website mokyingren.sg. These notes were put together by Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore, and he holds the FRCS in orthopedic surgery from Edinburgh. So really high-yield stuff here.
Absolutely. And our mission today really is simple. Nail down those core principles you need for the exam. HTO, fundamentally, it's about realignment. You're shifting that mechanical axis, taking the load off the worn-out medial side and varus, moving it towards slight valgus. And that's the key difference you need to articulate compared to, say, a UKA, a unicompartmental replacement. UKA manages the disease where it is. HTO changes the mechanics.
Okay, and right off the bat, something that catches people out is how the technique choice, opening versus closing wedge, affects the tibial slope.
Precisely. A closing wedge HTO, just by its nature, tends to decrease the posterior tibial slope. So when you do the more common medial opening wedge, the MOW HTO, if you just open it evenly front and back, well, you actually increase that slope. And why does that matter? Because that slope has a huge impact on knee stability, especially if you've got ligament issues already, like an ACL or PCL problem. We'll definitely circle back to that.
Got it. So before we even get to planning the cut, who is definitely not getting an HTO, what are those absolute contraindications, the things you just have to know?
Right, exam hot points here. Patient factors first. Severe obesity. A BMI over 40 is generally considered a no-go.
Okay, BMI 40, out. What about the knee itself?
Disease factors. Think inflammatory arthritis like RA. That's a contraindication. Also, significant tricompartmental OA. If the whole knee is worn out, HTO isn't the answer. And significant instability is key too. So a previous total meniscectomy, or if the collateral ligaments, MCL or LCL, are deficient, you can't successfully unload one compartment if the whole structure is unstable.
Makes sense. So if the patient is a candidate, the notes seem to really push towards the medial opening wedge technique. Why take on the risks of MOW, like you mentioned, patella baja or non-union, compared to a lateral closing wedge?
Yeah, it's a trade-off, but MOW has some compelling advantages. One, you preserve bone stock. That's really important because, let's face it, a lot of these patients might need a TKR down the line. Second, and this is a big one, there's generally less risk to the common peroneal nerve during that primary osteotomy compared to the lateral approach where the nerve is right there.
Okay, CPN safety is a major factor.
Definitely. So while things like non-union or patella baja are real risks with MOW, they're often seen as more manageable compared to a potentially catastrophic nerve injury or losing precious bone stock needed for a future TKR.
Okay, let's move to templating then. The Dugdale method comes up, aiming for the Fujisawa point. Why that specific point, that 62.5% mark from the medial side?
So the Fujisawa point, that 62.5% mark across the tibial plateau, or sometimes people use the lateral tibial spine, which gives similar results, maybe slightly less correction. It represents the target for your new mechanical axis. You draw a line from the center of the femoral head down to that point, and another line up from the center of the ankle to that same point. The angle between those two lines, that's your target correction angle. Hitting that point aims to shift the weight-bearing line just lateral to the center of the knee into slight valgus.
And the actual calculation for the opening size.
The rule of thumb still holds pretty well.
Yeah.
Roughly 1 millimeter of opening at the osteotomy site gives you about 1 degree of angular correction. Simple, but effective for planning.
What about bone grafting that gap, especially for larger corrections?
Yeah, good question. The notes reference the Elisal study from 2010. The key takeaway there is that for openings up to about 14 millimeters, you can often achieve union without needing bone graft.
Okay, 14 millimeters is the number to keep in mind there. Good.
Definitely useful for consent and planning.
All right, let's scrub in. We're doing the MOW-HTO.
Yeah.
Talk us through the key surgical steps. Incision placement first.
Incision is typically midway between the tibial tubercle anteriorly and the posteromedial border of the tibia.
And handling the soft tissues there. Pes anserinus, SMCL.
You need to retract the pes anserinus tendons laterally. Then you carefully elevate the superficial MCL, the SMCL, superior stele off the tibia, just enough to get your retractors in and expose the bone for the cut.
Where does the cut actually start? distance-wise from the joint?
Usually about 4 to 5 centimeters distal to the medial joint line, and you're aiming that cut upwards towards the tip of the fibular head, but not hitting it. But the most critical technical pearl, the thing you absolutely cannot forget intraoperatively.
Let me guess, the lateral hinge.
Exactly. You must leave an intact bridge of bone laterally, about 1 centimeter wide. This lateral hinge is crucial for stability as you open the wedge. If that fractures through, oh, that's a major complication.
Right, that leads nicely into the next level of detail. Biplanar osteotomy, the Lobenhofer technique. The idea is that vertical cut adds stability, right?
Correct. It increases rotational stability and provides more surface area for bone healing compared to a simple uniplanar cut. But there's a decision to make about where that vertical cut goes.
Superior versus inferior limb.
Yes. The classic technique uses a superior vertical limb closer to the joint line. The concern there is a potentially higher risk of causing or worsening patella baja because you're working closer to the tubercle attachment.
So some surgeons might opt for an inferior vertical limb further down the tibia.
Precisely. The thinking is that moving the vertical cut lower might reduce the patella baja risk. However, the trade-off is you might be increasing the risk of fracture propagation distally when you open the wedge because you're potentially creating a stress riser lower down. It's a judgment call.
Okay, that's a key nuance. Now let's link this back to ligament stability. This feels like prime exam territory. How does pre-existing ACL or PCL deficiency change how you manage the tibial slope during HTO?
Crucial point. You have to think biomechanically. If the patient has an ACL-deficient knee, the tibia tends to sublux anteriorly. So during your HTO, you want to decrease the posterior tibial slope, make it flatter.
Why decrease it?
By decreasing the slope, making it flatter, you reduce the anterior shear force on the tibia, making it inherently more stable against that forward translation.
Okay, and the opposite for PCL?
Exactly. If the knee is PCL deficient, the tibia tends to sag posteriorly. So in this case, you want to increase the posterior tibial slope.
To kind of push the tibia forward.
You got it. Increasing the slope encourages the tibia to sit more anteriorly relative to the femur, counteracting the posterior sag from the PCL deficiency.
And if you have, say, a young active patient who needs an HTO, but also has an ACL tear,
then you need to consider addressing the ACL as well. That might mean doing an ACL reconstruction at the same time as the HTO or potentially staging it. You definitely mentioned that possibility in an exam setting.
Okay, great. Before we jump into the complications fully, just a quick reminder for everyone listening, we're drawing all this detail from the Ortho Made Simple notes available on mokyingren.sg. Really comprehensive resource.
Absolutely. Worth checking out.
Now, complications. Let's face it, they happen. What are the big intra-op and early post-op ones we need to be ready for, beyond the basics like infection or slow healing?
Top of the list, as we mentioned, is that lateral hinge fracture. Happens intraoperatively if you're not careful or the bone quality is poor.
And nerve injury.
Peroneal nerve palsy. Much higher risk, as we said, with the lateral closing wedge technique because of the proximity of the nerve around the fibular neck. But it can happen with MOW too, sometimes from swelling or hematoma near the fibula, especially if there's a hinge fracture.
And then later on, post-operatively.
Patella baja. That lowering of the patella position can happen, especially with MOW, and affects knee function later.
Let's focus on that lateral hinge fracture. If it happens, what next? The Takeuchi classification is key here, right?
Yes, Takeuchi 2012. You need to know this. It classifies the fracture based on where it extends relative to the proximal tibiofibular joint. Type 1 is the most common. The fracture line goes into the joint or just proximal to it. Usually these don't cause major specific issues with stability or union, assuming the fixation is sound. Type 2 involves the distal part of the proximal tibiofibular joint. These carry a bit more risk of delayed union. You might need to be more cautious with weight bearing. Type 3 is the one you really worry about. That's effectively a lateral tibial plateau fracture extending from the hinge. This definitely changes management.
How so for type 3?
Type 3 typically requires a period of strict non-weight bearing, usually at least 2 weeks, maybe longer, to allow that plateau fragment to start healing before you load it.
You mentioned hinge fractures can link to nerve problems.
Yes, that's an important connection. A hinge fracture, especially if it displaces a bit, can cause bleeding and subsequent hematoma formation around the fibular neck area. That hematoma can compress the common peroneal nerve.
Okay, so let's say post-operatively, your patient develops a foot drop. Suspected CPN palsy. What's the immediate drill? Exam stations love this sequence.
Absolutely. First step, flex the knee. This reduces tension on the nerve. Second, remove any constrictive dressings immediately. Bandages, stockings, everything off around the knee and proximal leg. Third, apply a foot drop splint and an AFO to support the ankle. Fourth, you need to urgently investigate for a compressive lesion, usually a hematoma. That means getting an MRI or an ultrasound quickly.
And if you find a hematoma.
Then you need to strongly consider and likely proceed with urgent surgical exploration and decompression of the peroneal nerve. Don't wait.
What about nerve conduction studies, NCS? When do they fit in?
Well, the classic teaching was often to wait maybe 6 weeks for Wallerian degeneration to be fully evident, but modern practice is shifting. Many would advocate for getting NCS and EMG studies earlier, maybe within a week or two. Why earlier? Because even if the conduction study isn't dramatically abnormal yet, the EMG might show early signs of denervation, like fibrillation potentials, that can help confirm the injury and guide prognosis or further intervention.
And if, unfortunately, the foot drop becomes chronic despite all this.
Then the conversation shifts towards reconstructive options, typically a tendon transfer, like a posterior tibial tendon transfer, to restore some ankle dorsiflexion.
Okay, that covers the acute management well. Now, thinking longer term, many HTOs eventually come to a total knee replacement. What's the realistic lifespan of an HTO?
The data, like from the Finnish registry cited in the notes, suggests around 73% survival at 10 years, where survival means not having converted to a TKR. So a significant number do end up needing arthroplasty.
But does having had an HTO compromise the TKR outcome?
That's the good news, mostly. A systematic review from 2009 showed that TKR after HTO generally does well. The TKR survival rate itself is maybe only slightly lower, think 91% at 10 years after HTO, compared to maybe 94% for a primary TKR without prior HTO. So it's not a disaster by any means, but the conversion surgery itself is definitely not a straightforward primary TKR. It's much more like a revision. The notes highlight 5 major challenges you have to anticipate and manage. Think PIP, previous incision, implant, patella, proximal tibia deformity, PCL stability.
Okay, let's tick through those 5 PIP points for the exam. Number 1, previous incision.
Right. You always try to use the old HTO incision if possible. If you absolutely must make a new one, you need a good skin bridge between them. Minimum 7 centimeters is the standard teaching. Or for a medial HTO scar, you might incorporate it at roughly a 60-degree angle into your midline TKR approach. Skin health is paramount.
Got it. Number 2, implant interference.
Simple enough, the HTO plate and screws have to come out. Sometimes this can be tricky if screws are broken or stripped, or if the plate is very well integrated. You need the right removal instruments available.
Number 3, patellar baha. We keep coming back to this.
Yes, because it complicates exposure. A low-lying patella makes it hard to avert or sublux the patella safely to access the joint. The notes mention that up to 25%, a quarter of these cases, might need some kind of extensile procedure.
Like what?
Things like a quadriceps snip, rectus snip, a VY quadriceps plasty, or even a tibial tubercle osteotomy, TTO, to mobilize the whole extensor mechanism. Each has its own risks, of course.
Okay. Number 4, proximal tibia deformity.
The HTO fundamentally changed the shape of the proximal tibia, the slope, maybe the offset. So when you're making your TKR cuts, you can't just rely on standard jigs or landmarks. You often need to restore the joint line height accurately. This might mean using stems. Usually an offset tibial stem helps manage the deformity. But the notes make a good point. Stems are needed in maybe only 25% of cases, primarily for the deformity or poor bone stock. Not just because there are old screw holes distally. Don't feel you have to use a stem just for screw holes.
Right. Address the deformity, not just the holes. And finally, number 5, ligament stability.
Crucially, the PCL. After an HTO, especially an opening wedge, the PCL might be scarred, stretched, or just functionally incompetent. You generally can't rely on it.
So implant choice.
You should plan, by default, to use a posterior stabilized or PS knee design. Assume the PCL is unreliable and use an implant that provides that antero-posterior stability mechanically.
If you do encounter significant patella baha during the TKR conversion, what are the intraoperative tricks to manage it, besides those extensile exposures?
You can try a few things with the components. You could place the patellar button slightly more superiorly on the native patella, or you could effectively lower the joint line, slightly cut a bit more tibia, maybe 2 millimeter extra, and then use thicker poly or distal femoral augments to compensate. That gives the patella relatively more room. Transferring the tibial tubercle upwards, cephalad transfer is another option, but that's basically doing a TTO, which carries its own risks like non-union or extensor lag.
Before we wrap up, let's briefly revisit that other osteotomy mentioned. PFO, proximal fibula osteotomy. What's the basic idea there?
It's a different concept entirely. The theory is that the intact fibula acts like a lateral strut, supporting some load, maybe around 6–7% of body weight, according to some studies. PFO involves cutting out a small segment of the fibula, usually about 4 to 7 centimeters below the fibular head. By weakening or removing this lateral strut, the idea is you allow the lateral tibial plateau to settle slightly, shifting load away from the medial compartment, thereby correcting the varus.
Sounds simpler than HTO.
Procedurally, yes, it's less invasive than an HTO, but the massive caveat is the CPN. The common peroneal nerve wraps right around the fibular neck in that area. You need meticulous dissection and extreme caution to avoid injuring the nerve during a PFO. It's less commonly performed than HTO, but it's out there as an alternative concept.
Wow, that was a comprehensive run-through. We've hit everything from patient selection, the nuances of MOW-HTO technique and slope control, managing tough complications like hinge fractures and CPN palsy, right through to the complexities of TKR conversion. And just one final time, a reminder that this deep dive was anchored in the excellent Ortho Made Simple notes from mokyingren.sg.
Definitely. And as you review all this, maybe a final thought to ponder for your exams. Think about those trade-offs. We talked about the biplanar HDO, choosing an inferior vertical limb potentially to reduce patella baja risk, but maybe increasing fracture risk. Which complication worries you more in the immediate post-op period and for long-term function? A bit of patella baja or a complex distal fracture needing NWB and potentially delaying recovery? Understanding why surgeons make these choices, weighing the relative risks, that's really stepping up your clinical reasoning.
Excellent point. We really hope this deep dive helps solidify these critical concepts for your exams and your practice. We wish you all the best in your preparation. And for a little encouragement, here's a verse. An evil man is ensnared by the transgression of his lips, but the righteous escapes from trouble. Proverbs 12:12. May God bless your studies and your work.